There are two indications for TB therapy. First indication is a positive PPD without evidence of active disease, also known as latent TB infection, or LTBI. This is a designation reserved for HIV-negative adults. The goals in the treatment of latent TB are to prevent the development of active TB, as well as to avoid liver damage and avoid creating resistant TB, usually due to poor compliance. The treatment for latent TB is either 9 months of self-administered INH or 3 months of weekly INH and rifapentine given as directly observed treatment, abbreviated as DOT. Alternate regimens include daily INH for 6 months, daily rifampin for 4 months, or daily INH and rifampin for 3 months. There is a new 12-week INH plus rifampicin option. There are important drug-drug interactions with the rifamycins, including interactions with warfarin, hormonal contraceptives, some antihypertensives, antiarrhythmias, antidepressants, anticonvulsants, and methadone. The second indication for the use of anti-TB medications is in the treatment of active pulmonary TB. The treatment of non-pulmonary TB is beyond the scope of this class, and that includes such things as TB peritonitis, osteomyelitis that involves TB or Pott's disease, and these more extensive issues require the use of the management by a specialist, and is not something that would be managed in primary care. There are 2 phases of treatment for active pulmonary TB. The first phase involves a 2-month-long initiation phase, followed by a 4 to 7-month-long continuation phase, depending upon the drugs chosen. For your information, and not to be committed to memory, there are various treatment options outlined on the following tables from Up to Date. The preferred initiation phase, however, combines 4 drugs, and that's an important fact to note. The use of 4 drugs is an attempt to prevent the emergence of multiply drug-resistant TB. Here you can see several regimens. In the first column, you see the initiation phase, the continuation phase, the range of total doses, and the rating of evidence to support that particular combination of medications in the treatment of pulmonary TB. Isoniazid, or INH, is used for the treatment of tuberculosis as part of combination therapy, or for latent TB infection as monotherapy or part of a combination therapy regimen. INH carries a black box warning regarding hepatotoxicity. Patients with any risk factors for INH toxicity should be considered to have a relative or absolute contraindication to INH therapy. The mechanism of action of INH, it is a bactericidal anti-TB agent. It inhibits mycolic acid synthesis, and this disrupts the cell wall synthesis. In addition, it disrupts DNA, lipid, and carbohydrate metabolism. A fairly broad spectrum of activity. It's active against intracellular and extracellular Mycobacterium tuberculosis. It's active against atypical Mycobacteria species, including M. kansai and M. xenopi. Mycobacterium avium complex, however, is generally resistant to INH. INH absorption, distribution, metabolism, and excretion. INH is well absorbed after oral administration, approximately 90%. This could be delayed by food and acids. Patients with HIV infection may exhibit malabsorption of antituberculous agents, including INH. INH is widely distributed in the body, including entering the CSF and breast milk. Protein binding is less than 10%. It is metabolized by the liver, mainly by acetylation. It should be noted that about 50% of African Americans and Caucasians are slow acetylators, and the rest are rapid acetylators. 80 to 90% of Eskimos and Asians are rapid acetylators. Slow acetylation may increase the risk of toxicity. Rapid acetylation may increase the risk of treatment failures in once-a-week regimens in particular. The half-life ranges from 1 to 1.8 hours in fast acetylators to 3 to 4 hours in slow acetylators. It is renally excreted. INH inhibits the CYP450 enzyme system, and this impacts dilantin, theophylline, carbamazepine, primidone, and warfarin. It should not be administered with aluminum antacids. Oral INH should be administered 1 hour before or 2 hours after meals. The risk of peripheral neuropathy can be reduced by concomitant administration of vitamin B6. INH is available in tablets, liquids, and for IM administration. Clinical monitoring is very important. All patients should be instructed on the clinical signs and symptoms of hepatitis. Routine laboratory testing is not required for otherwise healthy patients receiving INH for the treatment of latent infection. Baseline laboratory testing, liver enzymes, bilirubin, alk phosphatase, serum creatinine, platelet count, is warranted for patients receiving INH for treatment of latent infection in the setting of suspected liver disease, HIV infection, pregnancy, during the immediate postpartum period, that is to say within 3 months after delivery, who have a history of chronic liver disease, that is to say hepatitis B or C, alcoholic hepatitis or cirrhosis, regular alcohol use, or risk of chronic liver disease. Baseline laboratory testing is also warranted for patients receiving INH as part of a combination regimen for the treatment of active TB. Patients at risk for hepatitis B or C should undergo serological testing for these infections. Clinical assessments should include assessment for symptoms of hepatic toxicity, such as unexplained anorexia, nausea, vomiting, dark urine, icterus, rash, persistent fatigue, weakness or fever lasting 3 or more days, abdominal discomfort, particularly right upper quadrant discomfort, easy bruising, bleeding, or arthralgias. If hepatic toxicity is going to develop, it is usually seen in the first 2 months of treatment. Assessment for symptoms of peripheral neuropathy is also important. Monthly monitoring of liver function tests should be done in patients who chronically consume alcohol, take concomitant hepatotoxic drugs, have HIV infection, pre-existing liver disease, or abnormal baseline liver function tests, including those with viral hepatitis, and anyone who's had a prior history of INH hepatitis, or persons who are pregnant within the 3-month postpartum period. It is not necessary to monitor renal function or platelet count in the absence of baseline abnormalities or other indications for such monitoring. Liver function test elevation. Patients who are asymptomatic with serum transaminase elevation less than 5 times the upper limit of normal can usually be continued on therapy. Transaminase elevations may decline spontaneously even while therapy is continued. INH should be discontinued if transaminase elevations are greater than 5 times the upper limit of normal, or if symptoms of hepatitis develop. Special populations in INH. Pregnant or breastfeeding women, the drug is considered safe in pregnant patients and there is minimal excretion in breast milk. Pyridoxine supplements are recommended for women who are pregnant or breastfeeding. Adverse reactions to INH include hepatotoxicity and neurological reactions. The neurological reactions are related to composition of the drug with B6. These can lead to peripheral neuropathy, ataxia, and paresthesia, and generally these can be prevented by co-treatment with B6. There is an increased risk for INH neurotoxicity in older adults, adults with chronic liver disease, in those who are malnourished or have HIV infection, individuals in renal failure, diabetics, alcoholics, pregnant or breastfeeding women, and children. Drug resistance involving INH is higher among certain United States patient populations, and this includes African Americans, Mexican Americans, and Indo-Chinese refugees. It's higher among foreign-born patients than United States-born patients. It's higher among patients with a previous history of TB than among patients with no history of TB. And primary INH resistance is more prevalent in developing countries of Southeast Asia, Africa, and Latin America. Moving on to rifampin. Rifampin is used to treat active TB. And note, a 4-drug regimen, isoniazid, rifampin, PZA, and ethambutol, is preferred for the initial empiric treatment of TB. When drug susceptibility results are available, the regimen should be altered as appropriate. Rifampin to treat latent TB is an alternative to isoniazid. It can be given oral or IV, 10 milligrams per kilogram per day for a maximum of 600 milligrams per day for 4 months. You will not be responsible for dosing on the exam. Rifampin has a longer half-life than rifampin. This is an important distinction to notice, since the new 12-week treatment regimen must use rifapentine and cannot substitute rifampin because the longer half-life is an important part of that treatment. Rifapentine can be used in the continuation phase in combination with INH as a one-time per week directly observed therapy. It can also be used with INH to treat latent TB as a one-time per week directly observed therapy of 12 weeks duration in select high-risk groups. These are groups who are at risk for not completing their therapy. This could be people who are marginalized, like migrant workers or homeless people, or people who, for whatever reason, move around a lot. However, if rifapentine should not be used for patients with HIV infection, children younger than 12 years old, pregnant or lactating women, or for individuals with cultural negative or extrapulmonary tuberculosis. As far as children under 12 go, there are some exceptions to that for children who are members of families where they're thought to be at high risk of not completing therapy if it were longer than the 12 weeks. Rifampin has some common off-label uses that I'll just mention here. In endocarditis with a prosthetic valve due to MRSA, for H. influenza prophylaxis, for meningococcal prophylaxis, not for treatment, but for prophylaxis, for meningitis with pneumococcal or staphylococcus, it's an off-label use. For nasal carriers of Staphylococcus aureus, it's an off-label use, and there's not a lot of evidence to support it. For non-tuberculous mycobacteria, such as Mycobacteria kansai, it's an off-label use. For pharyngeal chronic carriers of group A streptococci treatment, it's off-label use, but it is part of the infectious disease guidelines. For prosthetic joint infection, it's an off-label use. And for Staphylococcal aureus infections, adjunctive therapy. Rifampin does have some adverse effects. Effects that occur at between 1% of the population and 10% include a rash, some gastrointestinal upset with anorexia, cramps, diarrhea, epigastric distress, flatulence, heartburn, nausea. Pseudomembranous colitis can occur, and pancreatitis and vomiting. Hepatic liver function tests can increase up to 14%. Rarely, though, do people get hepatitis on rifampin. Caution has to be used with high doses, such as greater than 600 milligrams twice a week. This is associated with a high incidence of a flu-like syndrome and some thrombocytopenia, leukopenia, or anemia. And people can have a hypersensitivity reaction. Cautions related to the use of this drug include hyperbilirubinemia. If this occurs, the drug should be discontinued. Superinfections need to be cognizant that they can occur, including C. difficile and pseudomembranous colitis. This is more likely to occur with prolonged use. Alcoholism, even if the patient is sober, is a risk factor for further liver disease. And with hepatic impairment, sometimes you have to consider lowering the dose. Meningococcal disease, it is not used for meningococcal disease, only for the short-term treatment of asymptomatic carrier states and for prophylaxis for close contacts, such as household contacts. In patients with porphyria, it may cause an exacerbation. And concurrent drug therapy issues are largely related to medications associated with hepatotoxicity because it is a strong inducer of many CYP450 enzymes. Monitoring. Periodic baseline and every 2 to 4 weeks during therapy. You should monitor liver function studies, CBCs, mental status, sputum culture, chest x-ray 2 to 3 months into treatment, and patients should be notified that this drug may cause discoloration of soft contact lenses. It can turn them a reddish-orange color. Mechanism of action of rifampin. The drug inhibits bacterial RNA synthesis by binding to the beta subunit of DNA-dependent RNA polymerase. This blocks RNA transcription of proteins. ADME with rifampin, it's well absorbed, food may delay or slightly reduce the peak. It's highly lipophilic, which allows it to cross the blood-brain barrier very well, as relative diffusion from blood into the CSF is adequate with or without inflammation. Protein binding is about 80%. Metabolism is largely hepatic, where it also undergoes enterohepatic recirculation. The half-life and elimination, 3 to 4 hours, can be prolonged with hepatic impairment or with end-stage renal disease. Excretion in the feces, 60 to 65% of the drug, and in the urine, about 30% as unchanged drug. Part of a multi-drug regimen for active pulmonary TB, PCA is only used in the initial 2-month phase. The entire course, as you may recall, is 6 to 9 months long. Dosing is by weight in both adults and kids. Slightly higher doses are used in HIV-positive patients. Contraindications to PCA are acute gout, severe hepatic damage, and concerns related to adverse effects, hepatotoxicity, dose-related hepatotoxicity ranging from just transient ALT, AST elevations to jaundice, hepatitis, and or liver atrophy, although that's rare, have occurred. Disease-related concerns. Pre-existing hepatic dysfunction is an issue with alcoholism, and so it needs to be used carefully in patients with a history of alcoholism, even if alcohol consumption is discontinued during the therapy. Diabetes, it's supposed to be used with caution. Gout, PCA may inhibit uric acid excretion, and so acute gouty attacks have been reported. Used with caution in patients with chronic gout, and it's contraindicated in patients with acute gout. Should be used with caution in patients with porphyria, and it should be used with caution in patients in renal failure. Current drug therapy issues. With other hepatotoxic agents, you have to consider that you may get some interactions there, particularly with rifampin. The 2-month rifampin PCA regimen for the treatment of latent TB has been associated with severe and fatal liver injuries. The incidence increased with PCA doses greater than 30 milligrams per kilogram per day. The Infectious Disease Society of America and Centers for Disease Control and Prevention recommend that the 2-month rifampin PCA regimen should not generally be used in patients with latent TB infection. Patients should be monitored with periodic liver function tests, serum uric acid, sputum culture, chest x-ray 2 to 3 months into treatment, and at completion of treatment. Mechanism of action of PCA, it's converted to pyrazinoic acid in susceptible strains of Mycobacterium, and that compound lowers the pH of the environment. The exact mechanism of how that is bactericidal has not been elucidated. So this drug is bacteriostatic or bactericidal, depending on the drug's concentration at the infection site. It's well absorbed and widely distributed, including to liver, lung, and CSF. The relative diffusion from blood into CSF is adequate with or without inflammation. And that's noted because, as you may recall, some drugs can pass through the blood-brain barrier into the cerebrospinal fluid when there is inflammation that is sort of disrupting the blood-brain barrier. But this drug can diffuse into the CSF without the presence of inflammation. The cerebrospinal fluid blood ratio is an inflamed meninges, it's 100%, somewhat less than that without inflammation, but still significantly clinically meaningful. Protein binding is about 50%. It's metabolized by the liver. The half-life of elimination is 9 to 10 hours, and it's excreted in the urine. About 4% of it is unchanged drug. Ethambutol is used in the treatment of pulmonary tuberculosis in conjunction with other anti-tuberculosis agents. It also has an off-label indication for disseminated Mycobacterium avium, MAC, in patients with advanced HIV infection, and for non-tuberculous mycobacterium such as M. canzi. Contraindications include a hypersensitivity to ethambutol or any component of the formulation. Optic neuritis involves a risk versus benefit decision. It's used in young children, unconscious patients, or any other patient who might be unable to discern and report visual changes. Has to be very carefully considered. Ethambutol warnings and precautions. Hepatic toxicity has been reported, possibly due to concurrent therapy. Therefore, liver function studies need to be monitored prior to and during treatment. Optic neuritis may be caused by ethambutol, and it can be unilateral or bilateral. It results in decreased visual acuity or other vision changes. The drug needs to be discontinued promptly in patients with changes in vision, color blindness, or visual defects. The changes in vision are normally reversible, but reversal may require up to a year. And it should be noted that irreversible blindness has been reported. So you have to monitor visual acuity prior to and during therapy. So the evaluation of visual acuity changes may be more difficult in patients with cataracts, optic neuritis, diabetic retinopathy, and other inflammatory conditions of the eyes. Consideration should be given to whether or not visual changes are related to disease progression or the effects of therapy. And consultation with ophthalmology is recommended. Renal impairment should be used with caution in patients with renal impairment. Dosage modification is recommended. Monitor renal function prior to and during treatment. Ethambutol use in special populations. Again, in pediatrics, it only should be used in children whose visual acuity can be accurately determined and monitored. Generally speaking, it's not recommended for use in children less than 13 years of age unless the benefit outweighs the risk. In pregnancy category C, however, there have been reports of ophthalmic abnormalities in infants born to women receiving ethambutol. Used during pregnancy only if benefits outweigh risks. Breastfeeding considerations. It could be used in breastfeeding if benefits to the mother outweigh the possible risk to the infant, but some of it does show up in breast milk. Dietary considerations. It may be taken with food. Absorption is not affected. The drug may cause gastric irritation. Monitoring parameters with this drug, baseline and periodic visual testing, each eye individually as well as both eyes tested together in patients receiving more than 15 milligrams per kilogram per day. Baseline and periodic renal, hepatic, and hematopoietic tests. This drug inhibits arabinosal transferase, which results in impaired mycobacterial cell wall synthesis. ADME absorption is about 80%. It's widely distributed throughout the body, concentrated in the kidneys, lungs, saliva, and red blood cells. Relative diffusion from blood into the CSF is adequate with or without inflammation. the CFF to blood level ratio, normal meninges, 0%, inflamed meninges, 25%. Protein binding, 20 to 30%. It's metabolized by the liver to an inactive metabolite. The half-life is 2.5 to 3.5 hours. Excretion in the urine, 50% is unchanged drug, 8 to 15% is metabolites, and about 20% of unchanged drug is excreted in the feces. Other considerations. There are multiple regimens and schedules. Public health prefers the ones with less than daily dosing because it facilitates directly observed treatment. Asymptomatic patients on TB drugs without risk factors do not need monthly labs. The following situations require monthly labs: abnormal baseline results, a drug reaction is suspected, liver disease such as Hep B or C or alcohol abuse, pregnancy in the first 3 months postpartum, combination therapy including PCA in the continuation phase, and situations associated with hepatic injury, other medications, alcohol or drug abuse. So, hepatotoxicity, INH, rifampin, and PCA can all cause it. 20% of patients started with a standard 4-drug regimen have an asymptomatic rise in AST. Asymptomatic elevations in AST tend to resolve spontaneously. However, if bilirubin and alkaline phosphatase are elevated, this is consistent with rifampin hepatotoxicity. So, patients who are on these medications need to avoid alcohol, acetaminophen, other hepatotoxic drugs. In general, anti-TB drugs should be discontinued if a patient's transaminase level, AST/ALT, exceeds 3 times the upper limit with symptoms and over 5 times the upper limit without symptoms.